is not gonna be in the recording, this is just fun talk. Obviously, diabetes is a huge, huge deal. I could spend 4 days, the rest of the semester, however long, talking about diabetes. Because how many diabetics have you come into contact with in everybody in the South? And we're gonna talk about why we're predisposed for it. But there's no way for me to give you the time that you actually need to wrap your head around diabetes as far as the management of it. So this is kind of another big fluid and electrolyte section that will come back again and again and again and again because everybody has diabetes. So if you do not get all of it today, that's okay. But if you do not have it by next week, liver and thyroid, a better understanding, please come visit. Do not wait until exam 2 to figure out that, oh, I didn't know as much about diabetes as I thought I did. Because this is a huge one that will drive a lot of other components. So let me, there we go. So get you going there. So starting with diabetes, and we'll come back, make sure you have everything you need for that prep work. So what are some things, let's start with what is driving diabetes, like what's making it be so prevalent and so bad?
Obesity.
I like that. The obesity pandemic is a huge one. Then there's a very hot topic right now with Robert Kennedy Jr. and all of that. What's your other driver? Food supply, food additives. What are the things that are affordable? What are they based off of? Carbs, bread, all of that. So we're going to make it nice and easy. So we're going to talk about white foods. So breads, sugars, flour, pretty much rice, all the white things. So here's the fun part about rice. How many of you actually wash your rice? If you do, great. We're going to talk about why that's an advantage for diabetics. Because in Asia and Eastern Europe, or Western Europe, excuse me, where rice is a little bit heavier, so we're going and pastas, things like that. They wash. So when you're washing the rice, you're getting rid of those extra starches. It's pulling all that extra starch out, and that's what causes such a sugar spike. The other thing that they do is think about they produce rice in large batches, and so they'll typically cook rice once, and then they have it for like they'll just reheat. And so reheated rice actually helps to continue to break down there. The other thing that's done with processed rices, like minute rice and things like that, that granular fiber that's on the outside of the shell that actually counteracts, because that's why your sugar is going to go up. Fiber will help reduce the sugar spike. And so processed rices no longer have the fiber cap that will help balance out the carb that you're going to get. So anyway, we'll get into some food stuff shortly, but our food supply, put simply. And then the last reason is, have you noticed patients that are not even diabetic that will receive insulin when they're in the hospital? Because we know that chronic illness or illness, acute illness, can change how your body regulates its sugar, and so we have to intervene for them. And so you have to explain you're just getting insulin while you're admitted, you're not going to go home on it, but it's just to have that tight glucose control while you're with us. So for those reasons, diabetes is huge and prominent and everywhere, so we're going to talk about how to combat it. So everybody loves math, and I've had some cheaters already look ahead. I always just unhide these slides because, you know, 113 math gives everybody crazy, but it's math I promise you can get. Mr. Fuller has 40 Reese's Cups. I ate 29 of them. What does Mr. Fuller now have? Diabetes. No, unless they were the sugar-free ones, because you get the fake sugar, but diabetes. So y'all can do math questions like that. What about this one? All right, also the treatment plan, because here's what's going to be funny tonight. Everybody's going to have a totally different take on it. Some people take oral medication, some people take oral and injectable insulin, some people take insulin only, some people take the weekly shots that we're going to talk about. Everybody has a different package. So you can't, with diabetes, just say everybody gets insulin, because it's not that simple. So I like to refer to insulin treatment plans as if you have 4 pencils, 7 apples, how many pancakes fit on the roof? The answer is purple, because aliens don't wear hats. And so, and then grinding the gears with Family Guy, Peter Griffin, trying to treat sugar all day, and it still won't go down, no matter what you do. And so we're going to talk about those conditions as well. Diabetes is pretty complicated, so Perfect slide for diabetes right there. But we're gonna master it. So talking about as a whole, so we cannot any longer, we are in the term of saying diabetes. From this point forward, we will now say diabetes mellitus or DM for it, because there is another family of diabetes that you'll learn about called diabetes insipidus, and there's some others. But diabetes mellitus is referring to the glucose problem, and that's going to be where we cannot do anything with our carbohydrates, proteins, and fats. 4 families of diabetes. Obviously type 1, that is going to be where your pancreas does 0. You are insulin dependent, and it's typically going to be before the age of 10. It doesn't have to be, but typically before the age of 10, where your pancreas does 0, you are insulin dependent. And then type 2 is going to be the one that's either age acquired, metabolism acquired, just typically later in life. And so this can be where you may need insulin question mark, because your body is producing a little bit, but it may not be sufficient or enough for what you need. Maturity onset diabetes of the young, they call it MODY. This is where it functions as a type 1 diabetes, but you'll get it a little bit later in life. So this would kind of be your after the age of 10, but before you would have an adult or another comorbidity that would set the stage for diabetes, like syndrome X, metabolic syndrome. And your last group, gestational diabetes, this is people who are diabetic during their pregnancy, or but once they complete their term, they typically will go back to being healthy individuals, so they're only diabetic while pregnant. However, there are cases where patients will have gestational diabetes and roll over into type 2 diabetes. They just become diabetic and stay that way. So all of those things are possible. But type 1 and type 2, if you're focused on time, that's where we're going to spend our time. You will do gestational diabetes next semester with your OB content. And then MODY will be, I don't remember which semester, but when we're a little bit heavier on peds than this time. So we talked briefly about foods that spike. So your sugars and whites would be there. And so what are some good foods that don't spike or don't touch your blood sugar? Who? What kind? I love it. Legumes would be there. Whole wheat would be good, because it's something about that processed bleach that makes it extra more. But moral of the story, have me a handful of foods that spike your sugar, like woo, wow, and then have me a handful of foods that keep your blood sugar stable or don't create large spikes. And we're going to talk about what those spikes look like and what happens when you have severe spiking, just shortly. But glucose and insulin are related in that. I skipped this one totally. Just kidding. This paints you a picture of how your blood sugar maintains itself. So in a perfect world, healthy individual, obviously when you have high blood sugar, our beta cells in the pancreas, beta cells, I've already heard beta cells. Where else have you heard beta cells? Lungs, heart, those beta blockers. So that's how those drugs work across other systems. But hopefully our pancreas beta cells will produce some insulin, and then it's going to go out into our body and unlock, which we're going to see on the next slide, so where our cells can absorb the glucose in the cell, powers the cell for a little bit, it's gone, we used it up, blood sugar goes down. However, if we have more glucose than my cells need for the moment to store, our liver is going to absorb those and turn it into glycogen for stores. So when I'm away from food or don't have those food stores, my liver will break down that glycogen, throw it out into the bloodstream as glucose, insulin is produced, and the blood sugar goes down. On the opposite side of the coin, if my blood sugar is low, like we were talking about, we are going to have alpha cells, so the other side of the pancreas is going to go down here to the liver and take that glycogen from our thing called glucagon, and it's going to break down the glycogen and use it to get our blood sugar to go up. So has anybody seen the injection? It's typically IM, it's called glucagon, and that's, so if somebody has low blood sugar and their liver doesn't do that on its own, we will inject the glucagon to release glycogen, make that blood sugar go up. Okay, nice little pretty cycle. So if it's high, who's working? Beta. And I don't know how to remember that. And then if it's low, your alpha cells. And our next slide, without insulin, that glucose is just going to float around in that bloodstream. So that paints the picture for another group of patients we're going to talk about later, that metabolic syndrome or syndrome X. Those patients are so used to glucose and insulin floating around that we forget how to get in our own house. And we'll look at what that is. But insulin is the object that we need to get the glucose across the cell barrier. So our first one's type 2 or type 1 diabetes. And so what causes it is typically before the age of 30, but most oftenly is before the age of 10. But this is where beta cell destruction, our pancreas is out, we have no beta cells, therefore we don't produce insulin, therefore they are insulin dependent. It can be from two sources. It can be autoimmune related, that their pancreas kind of just attacks itself and it no longer works. And then if that's not the case, we would call it idiopathic. So type 1 diabetes mellitus idiopathic. That means just we don't know why everything's here, that just we're not making insulin. So that's that group. So our risk factors is typically a strong family history. Lots of folks there. So, and I can speak to my family that my grandfather was diabetic. Then my grandmother was diabetic later in life, around her mid-70s or so. Mom was diabetic, who has she is going to be our poster child this evening of all the things that happen to diabetics, because she had diabetes very early. She was a type 1. And then technically she was a MODY, but type 1 for your sake. And then surprisingly, there are some factors that they have now proven that can help encourage type 1 diabetes. So that's why we push those MMR vaccines. Coxsackie virus, not super prominent in this area, but you may hear it. Cow's milk was surprisingly, and then cytotoxins. So like if there's toxins in your cells that are not excreted well from the kidney or they build up, they can also help shut down the pancreas. So typically an autoimmune process, our insulin beta cells do not work, they're destroyed, no insulin, and can be caused even by pancreas resection. So hopefully these patients can get a pancreas transplant, but do you know of one that's been successful? Not yet. And that's because there's so many different types of tissues in the pancreas, it's hard to match them all. But they're close. UAB has almost got it down. So we'll see where that is here soon. So some pancreas transplantation works. You can get a section, but they've not had an entire. So looking at your spikes, we like our spikes to look like your top picture where we have our breakfast, lunch, dinner, or whatever your meal pattern is. They're not aggressive spikes. It should slightly uptick, but your metabolism should respond accordingly, produce enough insulin that your sugar goes down, and that kind of thing. When your sugar is low, that's what produces your hunger pains or your cravings for food. And so that's why we say that sugar is the devil, because it's very good at creating those cravings, and nutritionally doesn't really give you anything. So down here is going to be our sugar, sweet tooth person. So typically our blood sugars will lower at nighttime, and then when we have our breakfast, if it's carb heavy, because what do we love for breakfast? Bagels and cereals and all those sugars and whites that we talked about. So we get this huge sugar spike compared to up here. And so our body does insulin, produces insulin, it goes back down. Then lunchtime, y'all are usually pretty sensible. Y'all are at work, y'all are busy. We don't have a whole lot for lunch, it's pretty good. Then supper time, woo, I'm hungry, I eat all day. So boom, we get another one. And we have this huge response. And so because of the types of foods that you eat, you create those spikes. And so think about your mood throughout the day. Does your mood, hence the getting the hangry, should have had a Snickers, should have had a B8, all the things. If you have the mood swings with food, you're falling down here on sweet tooth line rather than our health line. and I'm preaching to myself too. And so things that we can do is try to choose foods that don't create those severe spikes, so that carbohydrates being the biggest group of those, so we don't get those spikes, and we can help, one, regulate our mood, and then we're gonna talk about the production of hemoglobin A1C in just a minute, which is a damaging agent to your vessels. Because obviously free-floating sugar I want you to think of as kind of scratchy or irritating to the vessel walls. So if you have lots of glucose in your veins, it's scratching that endothelial tissue and is causing scarring, which leads to all of these vascular diseases and myopathies and things that we'll discuss. So we like nice and level versus these unstable. So if you're looking at your patient's blood sugars in your clinical setting and they look like this, we need to do some education or do some adjusting to that care plan. We're not hitting where we need to. So what your patient's going to complain of, or how they're going to come into the hospital. The 3 P's of diabetes, you probably heard of them: polyuria, polydipsia, polyphagia. Polyuria means they're going to what? Pee a lot. Dipsia. It should say sepsia. If you were polysepsia is what it really should be. But polydipsia, they're going to drink a lot. Polyphagia, eat a lot. Because it's this vicious cycle of I eat a lot because all that sugar crave, because I don't have the insulin stored, so I'm going to eat a lot of sugar, and then my body can't get rid of it with insulin because I don't have any, so then I try to drink a lot of water to dilute it down, and because I drink all that water, then I'm going to pee all of it out, and it's just this vicious loop of my sugar goes down, so I eat again, so then I drink a lot to dilute it, and I pee it, and all that. So thinking about also sugar in your urine, what are they also very prone for?
UTIs.
UTIs, all the time. They keep a UTI. Okay. Then fatigue, obviously, because we talked about from the lack of being able to utilize that sugar well, because what are they missing that the sugar's got to have to go to the cell? They don't have insulin, so the sugar is not getting into the cell, therefore they don't get the benefit of the sugar. And then, so therefore their body's gonna have weight loss, so what do you think they're breaking down to have energy since they can't use the glucose or the food source? Muscle and bone, so they'll have, that's helping with the fatigue there because we're losing our muscle and bone tissues. So that's kind of painting you the picture. Hopefully we're gonna get it diagnosed that way. They're gonna do a hemoglobin A1C, they'll also do insulin sensitivity test, all these other things, but your most common ones are listed here. So the hemoglobin A1C, so let's talk about values. Anybody happen to know what's the favorite number? This or less is wonderful. 6, and then we're gonna get to Chuck's favorite in a minute. We're gonna argue your 2 resources that we have this semester for diabetes, Saunders and Hickey, they argue. So there's some gray area between 6 and 7. Some people say 6.5, 6.4, 6.7. We're gonna argue. We're gonna go all the way up to 7 to make it a nice clean number for you. So 7 or greater, they are diabetic and we need to do something. So that 6 to 7 range, we're gonna label pre-diabetes. And so that will be our levels. I think that's on another slide, but I wanted to mention it now while we're here. So your hemoglobin A1C, less than 6, we're gold. 6 to 7, pre-diabetes, greater than 7, we're gonna call it diabetes. And so then a fasting blood glucose, what do you think this is gonna be on a type 1? Super high, because they're not able to do anything with it, so it just floats around, and your liver can only store so much as glycogen. And then the other test you may see is a postprandial glucose, so this is where they'll eat. They'll measure it right after they eat, and then 2 hours again, because hopefully that number should decrease, but in a type 1 diabetic, it stays roughly the same, because the sugar can't go where it needs to. So what we're gonna do here, they are insulin dependent, so that is your pharmacologic intervention there. They can either do injections, they can do a pump, there's all sorts of options there, but they are insulin dependent. Nutrition management is oftentimes the biggest factor of keeping these patients well, because think about, we're going to talk about type 1, most of them are going to be 10 or less when they're diagnosed, and then when you're teenage years, what's going to happen? Because in my mind as a teenager, I eat food, I have insulin, I'm going to pop my insulin. Is that helping the situation? Because it's keeping your A1C up because it's not regulating your, as long as we have these sugar spikes, mountains, we're not getting anywhere with the disease. We're doing that wear and tear on that endothelial tissue in your vessels. So tons and tons and tons, most of the time, you're doing more dietary teaching to these patients for type 1 than anything else, because we need them to eat low, what they're gonna call low glycemic index foods. And that's gonna be your personal homework for time's sake, to make sure we get through all of this, to find me some low glycemic index foods. Because Cassie loves the nutrition questions. Y'all can say amen because of 112. Y'all remember the nutrition questions in 112? So, yep, they love nutrition. I don't know why, but they do. I was like, don't we have dietitians now? Don't we have this? Anyway, it still falls to the nurse. And then education about how they're gonna regulate. We're also gonna talk about some exercise-induced hypoglycemia. Because in a perfect world, when you exercise, you're releasing sugar stores that you have, so your sugar will actually elevate. But some patients don't respond that way. They'll actually hypoglycemia, so we'll look at those. And then detect and prevent complications. So knowing that they have diabetes, we're gonna learn in a couple of slides what complications they're prone for. But you also know, just in your experience, you're worried about already feet and infections because they have the sugar stores to do it. But we're gonna look at some more. Teeny tiny writing here, and we can zoom in. This is also straight out of your Saunders book. I don't think it's colored this way anymore, but these are all of your insulins, and we're gonna go through those at the very end, but we present them here. But since your type 1 diabetics are insulin dependent, they're gonna have a larger gamut of those insulins than a type 2. A type 2, what are the most common insulins that you give at the hospital name-wise? Who? I heard it, you said it right, but I just want to hear it loud. Humalog, Novolin, that one. Anybody got another one that you give often? Lantus, or Levemir will be the other one, but those are gonna be your insulin Glargine and insulin, Levemir, Detamir. More or less a handful for type 2 diabetics. Type 1s, we probably could use all of these. NPH, or your intermediate actings, this class is getting less and less popular with the invention of these good long actings, but some patients may require them, so every now and then you may see the intermittent. So please, if you've not visited this in your brain since 112, revisit your cloudy and clear insulins and how you would draw those up in the same syringe to limit your needle sticks. That sort of thing. But it just gives you some ideas for names. I don't expect you to know all of them. Just pick one and let that be your favorite, because most of them will be very similar in how they function. So just pick one per, and you should be okay. The most important part of your insulin administration is going to be your peaks and troughs, as well as your onsets. Why?
So if you give
Why you
the,
want to peak or trough?
so breakfast was comes to you at 7:30, you give your insulin at 7, the tray not there, boom, they sugar for the crash.
The sugar's right, and so now you have a whole other, you just created some more. So knowing when they would take effect. Also, it helps you to spot check them. So say they didn't do well for dinner, and the doctor, hey, they didn't eat well for dinner, do you still want me to give the long acting? Yep, go ahead. Well, I'm gonna be a good nurse, and I'm gonna spot check when that onset time is, or the peak time is, because between them not eating well for dinner and the long-acting insulin, troughing in the middle of the night when their sugar's gonna go down anyway, I wanna spot check them. Because there's gonna be a nurse out there that's gonna go, oh, look, they're sleeping. No, they're hypoglycemic and in a coma. Because they didn't eat dinner and you gave them Levemir and it's 2 a.m. and their body's circadian rhythm's dropping their blood sugar too. So go spot check. So we're gonna learn an acronym: cold and clammy, need some candy, and that's coming. So when we would give insulin also needs to influence it. So if your patient's gonna be a busy, non-compliant person, I wanna pick one of these long-term options down there, or if they're a very compliant patient, I want the rapid quick hit because it'll keep their sugar from spiking. So depending on your patient will depend on the type of insulins that we have. So hopefully, usually breakfast is the biggest spike of the day because we wake up, most of us hyperglycemic just due to natural processes, and then of our carby American lifestyle that we have for breakfast. And so anyway, you see what we would like our Glargin to do is, our Glargin's gonna try to help keep us on those in-between times nice and low when we inject it, and then our Lispro or Aspart, whichever favorite rapid insulin you have, your logs and Lins, will help to take it down. Most of the time, they're gonna do a sugar check 4 times a day. We can also insert here talking about compliance. So, what is this new fancy invention that's out there? Instead of having to do a finger stick all the time and not losing the sensation in my fingers, Drew's pointing at it. Yeah, Freestyle Libre, Dexcom, several different brands. But we know that if I have that chronic watch, if my sugar goes up, I can treat it before it even spikes. So we like those chronic glucose monitoring systems. Yes?
I had a patient recently that had one, and his was attached to his phone, like it,
Mm-hmm.
and when I did the finger stick anyways, and they weren't always lined up, like the finger stick was usually like 20 points higher than his phone.
Which is, if you think about it, accurate. So, for the chronic monitors, they are, not deep enough, they're not actually drawing blood. And so your blood store may actually be higher than what's available in the tissue. But the other thing that they're supposed to do, if they're that far apart, it makes me think he's not doing those, let me think about it, what do they call them? Calibration, that's the word, thank you. That they ask to do calibrations because it will match your backup meter in case you have a funny reading to your chronic meter. But yes, there's gonna be a little bit of discrepancy between them because the chronic monitors do not actually draw blood.
Also, recently, in the ICU, it was strange because it was kind of flip-flopped, in that when we draw from a line, like if they have a midline or central line, and the nurse draws the blood to give for the test, usually that's super accurate, and their fingers might be inaccurate because
I like
they're
it.
not getting enough blood, but in this case, it was the opposite. He drew from the line, and it said like 40 something, and I was like, oh, we're in trouble, and he's like, hey, just in case, check the fingers, and the fingers were like 130, so. Don't know why that happened, but it was weird.
I can't think of a reason for it to be the opposite you just talked about.
Strange.
But the extremity one, you will see that. So if like you can't get a good SpO2 or oxygen saturation on your patient's finger, probably not gonna get a good glucose reading either. You'll see them use their earlobe sometimes, or toes, which is gonna be the worst, but you will see crazy stuff. All sorts of places to check it. But, if your patient is symptomatic and you get at least one low on a reading, we'll treat them. So looking at the devices most common for your type 1, we like the insulin pens. This is the old school ones because your type 1s, remember, do not produce large amounts of insulin. And who wants to tote around a cooler and keep the insulin and all that, which you're supposed to keep it cool. They don't at the hospital, but you notice that's why those medication rooms are freezers, because they're trying to keep those vials in the supply fixes low. But a pen is much more convenient, especially for your gentlemen that have the pocketed shirts. I can just throw my little insulin pen right there with my other stuff, going about my day, and every time I eat. And so you need to teach your patients when they're putting something in their mouth, they need to be injecting to cover the food that they're eating in their mouth. Because by the time the insulin acts, the food will be ready to start digestion. So it's on board and hitting the same time, and we won't have that sugar spike. We'll just keep that nice little flat line. Most of them are gonna have a click. I'm a terrible human. I did not bring them this evening. Remind me next week and I'll have them out in the lab. So while y'all are sitting waiting to do your validation, I'll have them out there where y'all can toy with them. But they're typically gonna go by number of units. You just click up however many units they need, and then they'll go. It's most of the time, every drug is different, but general rule, we're gonna talk about a 15-15 rule. Most of the time, you'll get 1 unit of insulin for every 15 unit of carbs, or 15 grams of carbs. So I don't have anything part-wise. I'm gonna have to pick on Ally, cause it's the only thing I see from them. On the Lay's, if you'll check out your little potato chip back there, let's see how many carbs we got. So in theory, we need about at least 1 unit of insulin to cover the bag chips, preferably 2. But that's still a little over, but that just makes sense. So for every 15 grams of carbs, so you also see who walks around with a food diary and sitting there doing their macros during the day. You do your macro, they need to, if they're type 1, do your macros, so you can cover exactly what you got. But mom is so proficient at this point. Share, what you got? Yeah, look, I wouldn't either, I would be the worst one, cause I'm the worst food journaler. I'll try to do that Livestrong app and scan everything or log it. 2 or 3 days in, I'm like, this is too much, so we're just gonna eat, it's fine. And so I would be a very horrible diabetic. But mom, she's been diabetic so long, she can just about just eyeball what her portion is and cover it, pretty good. But I'm sure it didn't start that way. So even better than the pen for this group is the pump, because literally it can give a basal rate, so it can kind of act as long acting if we need it to do that. In addition to, we can do bolus through there. So everybody heard the word basal before, basal insulin? It's just like where it's chronic, or a basal dose, just chronic, and then we can do bolus to cover the food. All right, so like I said, the problem is here, kids in the cafeteria, they're gonna go through, we're gonna get pizza and hamburger and cookie and all the things, cause I got insulin, we're gonna shoot up, boom, no problem. Yeah, it's gonna be a problem. Anyway, yes?
What's on the left side of the
That is one of those continuous glucose monitors.
Oh, okay.
So that would be one, that's the Dexcom 6, I think, in that picture, cause those go on the abdomen, Dexcom 7's on the flat. Yes?
When I did my school nurse, they like had put in the bolus for every like diabetic child.
Mm-hmm.
How do they do that and why do they do that?
Just, we don't want, at least for school nursing sake, I don't wanna trust the kid to, per se, because at the end of the day, if the nurse is legally responsible for the health of the child, I want to verify that that's what they got, and then I can also, during that time, review what's been given. So like if they gave themselves something, maybe the teacher gave a candy bar and they thought they were gonna real quick, the nurse is gonna look and see that they gave extra insulin too, so it helps them gauge what's going on. It's more for legal responsibility because there's several children who are mature enough to do their own, but it's the legal, if I'm legally responsible for you, I want to do it and I wanna see the window.
I went to Auburn Middle School, and the nurse, she just takes the student. Like, he had to come in, and she got the monitor,
And-
well, she was like 3 something.
And that's just their personal trust, I guess, of this. What do you think's the best?
I mean, I prefer the.
Best, that would be best. But if you trust them, or you have that work relationship that they're good, they're compliant, they're not, every time you check them, they're good, basal, then I can probably text that student. But, you're gonna know the ones that you're gonna have to call in and watch. You're gonna know. If you have not, since 112, what degree are you gonna give your insulins and sub-Q injections, 45 to 90, depending on the fluffiness of your patient? How fast are you gonna inject insulin?
10, 15.
Thank you, Lex, that's exactly right. I want it slow, yep. You're gonna find out slow is the answer for any kind of injection, IV push, all the things. Why do we not like fast insulin injections? There's a side effect. So everybody pull out your U-Central right quick. Lipolysis. Yep. So what's lipolysis?
Dissolving the fat.
You're gonna give them artificial cellulite, essentially, is what's gonna happen. You're gonna give them artificial cellulite that way. And then, obviously, doing it that way too, it does not work correctly, because it may damage the tissues and not get where it needs to absorb correctly, so just go slow. Do you remember Miss Martin's rule about how fast to push? Like 1 ml equals 10 seconds? So if it's like 0.1, that's a second, so that's nothing. But just getting you to think, rather than you going in there going, like you're shooting it as soon as you touch their skin, no, like inject it, push it, give it a second, bring it out. And so giving it a second to work. Several subacute injection sites, just to review that we have them. Oftentimes we're good at using the back of the arm, but the ones that are surprising me is the upper part of the glute, just below, where the peach would be if you had a big old booty, we'll put it that way. And then your scapula, we can also use if you have some back fat, back wings, we can use that. And then complications or worst case scenarios, these are our dangers. So diabetic ketoacidosis, there's a slide for that. That is where your sugar is extremely high and you are in an acidotic state, hence acid-base balance. See how this does come together? And then also ketones in the urine. So that's where all of those things come from. They will also have a fruity odor on their breath from the acetone, again, ketones on the breath. And then hypoglycemia, this is the one kill you dead. So the one I'm most concerned with, I don't like elevated blood sugars, but I got some wiggle room before you have some severe problems. Hypoglycemia, kill you dead. So we do not like low blood sugars. So when is a blood sugar considered low?
70 and below.
Technically 70 and below, and then where am I starting to get in the danger zone?
40.
That's your kill you, 35, 40, I'm starting to, death, I'm worried. But 60s, where they're gonna start getting some of that confusion, their fight or flight response is gonna kick in, so they're gonna start getting sweaty, and jittery, that kind of thing. And your diabetics who've had these happen typically are accustomed to what they feel like. Fun fact, if you have a chronic or a patient who's chronically in the 3, 4, 500s, they will still act hypoglycemic at 200 or something like that. Because they're so accustomed to, their brain is so accustomed to that sugar level being 300, that's where I function. They will appear because of that 100-point drop to their brain, they will act hypoglycemic. So they may not be low, so that's gonna be a weird thing for you sometimes that, this patient's 200 and I'm giving them glucose? Yes, because they're starting to get that mental confusion also. We're being too aggressive with decreasing that rate. Same.
So, y'all know I love TikTok, but I was watching TikTok and this man, he has diabetes and he was asleep and he just said he didn't feel good. So he woke up and checked his blood sugar, it was 32, right? So then he drank, I think he drank some juice and he ate like some peanut butter crackers or something like that.
But see, that's gonna take like 30
Yeah,
minutes or so
because
to
he kept
have, so it's
rechecking
gonna
it.
keep.
But it was like the highest, I think, after like I watched the video, he only got up to like 50. So would you recommend him go to the hospital or no? It's like he had sugar, he had peanut butter.
In a perfect world, you would want them to have either glucagon or the Dexa gel. It's kind of like a clear gel they can put under their tongue, and it dissolves because your sublingual blood supply is really good and you can get sugar in quick that way. That crap is expensive. Now, the Dexa gel has gotten cheaper. What was your other one? The little sugar crap?
Now they have Baqsimi now, where
I
it's,
didn't know this one.
it's basically, it's like inhaled glucagon, so you put it up your nose. Like, that's what they give you now instead of glucagon, like, they don't give you glucagon really.
Can I ask cost effectiveness? Is it expensive? Insurance cover that? Is that?
I think mine covers the same amount, but, yeah, it's like you put it in almost like the Flonase.
Now, everything's going intranasal, because even the Narcan's going intranasal.
Some
and-
schools have that too.
Cool. So tell me that one more time, I won't write that in, because that is a new drug to me.
Baqsimi, BAQSIMI.
BAQSIMI?
Yeah.
Like,
I'm sorry. So what blood sugar, cause I know hypoglycemia is going to coma, but what number would they kind of slip into? Cause he's at a 30, he woke himself up.
obviously, he is so accustomed to hypoglycemic reactions that he can function at that level. Somebody like me, I would not ever be used to a 32, I would probably be in a coma at 32. And it's because my brain is not used, so people who can function that low, they are accustomed to so they've adapted for their brain to function at that low of a glucose level. where my brain would not function at that, I would be,
So you would typically say like a 40 or below probably would not.
but the book is gonna tell you danger zone is at 50. You should start getting that mental confusion or for a normal patient. Now granted, people who adapt, they're gonna be different. But most of the time, less than 70 is considered hypoglycemia. 60 is where you're gonna start getting those fight or flight responses, the sweaty, confusion, hey, something's off, I don't, and then 50 or less, we could start coma per book. Strangely, in some of your videos that are out there, you may hear about nanograms per deciliter. We do not function that way in this part of the world. NCLEX does not test you on nanograms per deciliter. Just understand that your facility may, because cutting edge, everybody's going to Celsius and the metric stuff. So there may come a point you have to learn the deciliters one. It's gonna be where they range from 0 to 8. So if we go all the way back to those spike slides, see how it's a 0 to 8 for your deciliters. But that's the nanogram. It should be per deciliter instead of milliliter. But if you told me that somebody's glucose was 4.2, I think they're dead. But really, they're probably talking about the other system of measurement. Caroline.
So if someone was in a coma and, well, I don't even know if it's possible for like your blood sugar to go up there in a coma, but would they just give them like sugar through their IV or
So
something?
there's gonna be that other option we're gonna talk about when we get to drugs at the very, very end. I saved the best for last, because the drug, if I did drugs now, y'all would be dead the rest of the lecture, so I saved those for the end. But, they'll get in what they call an amp or an ampule of D50, which is the dextrose 50% in water. So it's half, it's sugar water, simple syrup, you give them simple syrup in their IV.
Can their blood sugar go low in there?
Good, yeah.
Is that gonna have any like lasting effects on like their body if they go into a coma like one time, or is it?
One time, not necessarily, but so think about, what is your concern with coma? Brain function and really those involuntary functions, so breathing, heart rate, that sort of thing. The other big issue could be if, depending on my respirations, depending on how long they're oxygen deprived because of the coma, that could cause like indefinite brain damage. Not often, but in severe cases, it can, prolonged periods. Yes?
Sorry, but Bella had a patient last night.
I know, it was before I got.
But it's,
But whatever. And
there's a
the-
patient under your umbrella,
And
okay.
the patient, and she was trying to kill herself, and she took non-targeted insulin. So what would the treatment be? Bella was there for treatment.
Lots
She
and
got
lots and lots and lots and lots and lots. Sure. Like,
How do you
you were,
survive that?
hmm?
How do you
It was
survive?
long acting.
Huh? Oh, that's, okay, so she just had to be under care for a while. So essentially, she getting D50 until her sugar and all, so, Levemir lasts 24 hours, so she'd be getting D50 plus probably some pushes of 50 until the insulin wore off.
But the fast acting was just took her out of now.
Fast acting, the 30-minute one, gone goodbye. If it's been long acting, gone, I couldn't do, call the ambulance, been gone. So true story, there's a documentary series on Netflix, where there was this home health nurse who would, essentially weasel her way into being good with the family, and she would pick the patients that had like no next of kin and things like that. And she literally would inject insulin in between their toes because it's hypoglycemia, so there's no, and nobody's checking in an autopsy between your toes until just, all of these patients that are dying like before they're expected or, is under the care of this people. So they started investigating, and when they went back to do autopsies later, they went back and saw the bruising between the toes, because after your body dead, it'll start decaying, and so it had a different decay than because of the trauma of an injection in between the toes. So that's how anyway, whole documentary series, insulin is one of those kill you dead, so don't be getting murder mystery ideas for y'all, you will be finding out. But I don't remember, but it's on Netflix, if you'll do,
There's two of them. There's a male.
the only one I know is the female, because that one had to do with where, because she would actually be in their will and testament to get inheritance or be left something, or they would bestow her something, and then she's like, got what I need. I think it's like Black Widow nurse, or the Black Widow nurse, or
Is it the
something
Good
like that.
Nurse?
The good nurse.
That was the
Huh?
man though.
Yeah,
That's the man.
That was good. No, that was.
No, that's the.
Isn't the good nurse the man?
Yeah.
Eddie.
Oh, okay. But I have the book, there's another book, called Good Nurse, and the book is about a male nurse who would add, I'm trying to think, what, he would put additives in IV fluids in the ICU.
Insulin.
Was it, it may have been, but it was a book, and he was up in the Midwest, like Chicago, Indiana, somewhere up there. But insulin's just natural process. Okay, there's another question, I think. Do y'all have another question? And I missed it, because of the, okay. Moving on, so hypoglycemia, that's your big one, kill you dead. I'm more worried about that than anything else happening to them. Dawn phenomenon, there's a slide coming up, but that's essentially like the name, and the dawn, early morning hours, we're gonna have a surge of hyperglycemia. And I haven't even eaten yet. And then Somogyi effect, this is where they will initially dip down like they're supposed to, but the body responds atypically to that. So instead of at nighttime where it just goes down and stays low until you wake up, and most people get dawn phenomenon, Somogyi is where it starts to dip, and everybody's like, whoop, nope, not today, and will just skyrocket in the middle of the night.